Hey everybody, this is Dr. Paul Thomas with Plum Health, and this is our 4th episode. We're talking with Matt Ohrt about healthcare and how it's broken and how there's a really good solution on how to fix it via employer groups. So thank you so much for joining me, Matt. It's great to have you here.
Thanks for having me. It's great to be in Michigan.
Oh, welcome. Yeah, you are from Wisconsin.
I am.
So everyone knows that healthcare is broken, but on average, how much are companies overpaying for healthcare and health insurance costs?
It varies, but yeah, as on average, a lot. I mean, I heard one the other day they were paying $30,000. What we use a measure called per employee per year, total cost, and it was an event in Illinois, and I was speaking, and the owner spoke up and said, "We're at $30,000 per employee." I've heard the highest I've heard is $40,000.
$40,000 per employee per year.
Yeah.
And that includes their family members, right?
That's including the whole family in that measurement. Yeah, PM. You could break it down if you wanted to. And now that's not an average. Average is probably in the maybe in the low 20s to mid 20s, which is still a big number.
Sure. I mean, you could buy a really good used car, $20,000 every single year on what we're spending, average Americans who are employed on their health care.
And going up pretty fast, and I think it's going to pass the house payment probably before too long, right? Where it becomes the biggest expense in the family.
Indeed, yeah. Typical mortgage might be $2,000 a month. So yeah, you could easily see that swinging up to $24,000 a year for families just for their health care.
For sure.
And I think a lot of employees would like to have that money in their pocket. And I know that I've read some studies where employer groups are not giving raises because more and more of the what would be their payment goes to their healthcare costs. Can you speak to that?
Yeah, I mean, my previous life is an almost 25-year HR career. And I can tell you, I was the one that always led the enrollment meetings. So that's the first thing, and sometimes the only thing that employees, they really don't have a strong interest in healthcare. It's maybe not, or the benefits, it's not the most interesting topic to them.
Totally.
And it's complex, so they don't understand it. But when you go into that room, that's what they want to know. How much is my premium going up? Of course, deductible is a whole nother level before insurance kicks in. But how much more is coming out of my check and how much of my raise is gone? And in many cases, it's all of the raise. Right? It's really eating up the raise completely.
And I think what a lot of people don't understand is that an employee might spend $200 or $300 per pay period or per month on their health insurance costs, but on the back end, the employee or the employer is spending $1,000 or $1,200 or $1,600 monthly on that employee's healthcare. Mm-hmm. And so that as an employee, you really don't know the costs. You don't know the true cost of what's being spent on your health insurance and healthcare costs overall.
Yeah, it seems, and we see this trend where you pay a lot more and you get a lot less. Employers are starting to, probably, since the mid 80s or so, have started tweaking their plans. So it used to be many were 100% of the healthcare cost, and then it went 90-10, and then it went 80-20, and we're seeing even 75-25, and so the employer is just trying to find a way to keep their health plan. Many have lost their health plans because they become unaffordable.
Indeed, and one way to keep the costs the same is to raise the deductible in a higher price environment. So your family deductible might have been $1,000 10 years ago, and then it might have been $3,000 and then $10,000.
I was talking to a farm couple a while back, and the premium was $1,000 a month. And then the deductible was $14. So I said, you're paying, right? So you break it up, it doesn't sound as bad, but you're paying $26,000 before insurance would kick in.
Indeed.
And you're paying $12,000 even if you never use any health care. I said, you might as well put it in a savings account or something. You could pile up that money and almost your own health share version or something.
So in the book and in some of your talks, you tell this amazing story about purchasing a vacuum. $350 vacuum, and you had to fill out a purchase order, but you spent a huge amount of money on health insurance early in the day. We'd love to hear that story because it's just such a great example of the insanity of healthcare costs.
Yeah, it's funny how that works out. That was just a real day for me. It wasn't meant to be a story, but it certainly turned into an aha moment for me. I had one of the things I had done at Merrill Steel is we had taken the custodial staff and we said we could hire them cheaper than paying. We get one person for like 20 hours. I said I could hire like two people full time for the same money, right? So that's how it started. And then they reported to me. And so, and then of course, then you get all the fun with the custodial challenges. But our vacuum broke, and it's a vacuum that was like this, I don't know, 24 inches wide. It was like this monster push vacuum. And we had repaired it like 4 times, and it was to the point where we needed to replace it. So I called the rep and I said, here's our situation. And they had like the new version. It looked almost the same. And then I went to down the hall, like literally 3 offices down to what we called purchasing, is the department. And I said, can I put this on my card, or how do you want me to pay for this vacuum? We need a new vacuum. And he said, well, we have a process for purchasing for that, which is all of this, by the way, is very typical of working in the Fortune 100, 500, family-owned companies. This is the same as every company I've been with in my career. And so I was kind of used to that, but a little bit annoyed by it. But I'm filling out the paperwork that afternoon, which is a good process, right? I mean, we should evaluate.
You got to get 3 quotes and say why this one's the best one to buy. And
you got to put your justification in writing. And I had made the decision really fast, right? But then now I have to document it. So as I'm filling this out, I'm just, a little bit aggravated. I'm kind of glad we're doing it as well. So I'm filling this out so we could get the vacuum paid for. And then I realized just that morning, this was before we started a lot of our efforts to make it better. So our stop loss was still high. In fact, it took a couple years to get it down because it goes on a 5-year average. But we went from, 3 hits, 2 hits, no hits, no hits, no hits. But as I'm reflecting, I had just signed off on our stop loss that morning. And all I had was a nod from the CFO. I didn't have any forms. I didn't have to go to the president or the owners. And it was around $700,000.
Yep.
And that was the epiphany for me is, why is purchasing healthcare is a purchase, is it not? For a service.
Purchase. Usually like number 2 or number 3 on the company's profit and loss statement. We make the joke that GM here locally spends more on healthcare costs and health insurance than they do on steel.
Yeah.
Right.
And Starbucks spends more on coffee than they do. Or it spends more on healthcare than they do on coffee. Yeah. But at Merrill Steel, it was the 3rd largest expense. So it was what would be steel, and then wages, and then healthcare.
Wow.
And so I realized, I think at that moment, there was nothing unique about this with Merrill Steel. This is maybe every company across America, but we're not seeing this as a value-oriented healthcare purchase. We're somehow viewing it as a benefit. And if you cut costs, therefore you've cut the benefits. And we certainly don't want to do that in a highly competitive staffing situation. That's a myth. That's a myth. And when you realize that you're overspending for healthcare services, companies already have the skills to manage these things. I even joke about office supplies. If you've ever, in the corporate world, it almost sounds like it should be an Office episode. I was just watching before I came over. Please return your folders and your notebooks, and we'll save like $492 on folders, right? Which is a good, wise thing to do.
Great thing to do for a company.
But we'll spend $5 million on healthcare, and we should be spending $3.5 million per year. I mean, ridiculous numbers.
Totally.
So, yeah.
And it kind of speaks to the priorities or the perverse incentives, perhaps, of healthcare purchasing.
I think the industry has brainwashed maybe or created the narrative, maybe as a friendlier way to say that we think of health care. So we purchase health insurance, and we think that's purchasing health care. And they're 2 very different things, as you well know.
So that's the bad news, right? And let's move the conversation to the solutions, right? Mm-hmm. And you've got some really compelling ones. So you're wanting to change the structure on how employees purchase healthcare by using free market principles. Mm-hmm. So who is a good candidate what size employer group, who are the employer groups that you're working with to change how they spend, and how do you do it?
Mm-hmm. Yeah, I think even, and most people have plans, but anyone who's purchasing healthcare can benefit from this kind of discussion. But there's really kind of two or three categories of employers. You'd say the first one would be 50 or less employees. And health shares have really taken a lot of that market. That might be the best way to fund those health plans. They work a little differently, but that's really become the prominent way for that. And then we might say generically 50 to 150 might be level funding, and then above 150 would be traditional self-funding. Now, both of those are really self-funding. So if you wanted to keep it simple, you'd just say above 50, self-funding, employer self-funded plans funded by stop loss.
Yeah, I think for our audience, we need to spell that out because it is complex. Most people are like, okay, I work at a company, they buy Blue Cross or United or Cigna or Aetna, and I pay a small premium. So that's most people's conception of what health insurance is through their employee. But now you're throwing in that, self-funded. Can you walk me through what that means and what that looks like? Let's say there's a manufacturing company and they have 200 employees. Should they self-fund, and what does that look like?
Yeah, it used to be too, by the way, it used to be that you could just renew your full insurance and everything was fine until the cost of healthcare started getting out of control. But there was a story, for instance, I met with a body shop and they had 20 some employees and he just came to me for help. What can I do? And so he said, we're on one of the big insurance plans now, but it's going up 37% in 1 year. And even if I could afford the 1 year, I'm concerned about the trend. I need some kind of sustainable solution. In that case, so if we break that down, and I think your question was about self-funding, but in that case, a health share was the best option. So what he did was he offered the health share option for the group plan or the same old plan. And I said, just explain it well. Every single person took the health share plan.
Wow.
And so the concept of self-funding, so in that case, the employer might pay 80% of the health share fees. So it's a little simpler in design. If we go into normal self-funding, the employer is still protected. A lot of people will say things like, we tried self-funding and it didn't work, or all these kind of misperceptions. That's really a faulty statement because that's how you funded your plan, but you never talked about a medical strategy of how you lower the expenses, which is really the root cause of healthcare. It costs too much. But in that case, you would say the employer might pay 80% and then 20% for the employees. And then in terms of a total cost perspective, the employer is paying the first 80%, and there's also an individual deductible too. But say the first part, and then if things get extreme, that's when the stop loss would kick in. So the employer is still protected. The employer is not putting their neck on a stump and saying, we're risking our whole business. And that works really well when it's done right.
Yeah, so if I'm hearing you correctly, as an employee, if I get sick, I go see a doctor or go to the hospital, and that bill goes to my employer and not an insurance company like Blue Cross or Aetna or Cigna. And the employer is going to pay 80% of that bill, and I'll pay 20% of that bill or something like that.
And it's in simple form, yeah. And so there would be on the stop loss policy, there would be what's called an individual spec, and then based on the size. So it might be for the employer would pay the first X amount for for each individual, and then there'd be an aggregate spec as well. But that's right, the employer pays the first portion along with the employee and their copay or deductible and so forth. And then if things get extreme, then there's coverage.
Yeah, so we're frustrated because we're in Michigan. Specifically, we're in Southeast Michigan, Metro Detroit. We're sitting right now in our Royal Oak office. And Michigan seems to be very much a laggard in terms of direct primary care adoption and self-funding adoption versus like Kansas or Florida or Texas or Wisconsin, right? And, we just talked to a company down the street that has 1,000 employees and they're buying full insurance through like Blue Cross Blue Shield. And we're saying, you guys need to be self-funded because that's one of your big steps to lowering your costs. So tell me what it takes to change a state's ecosystem or the market like you did in Wisconsin, right?
Yeah. Yeah, and it's really regional too. Just a quick point is, it's very regional. So I met when I was in Denver, I'm not sure if you were there, I met the only one, they thought they were the only one from North Dakota. And in Wisconsin in 2020, we had 15 DPCs, but then today we have 131. So Wisconsin is averaging over 25 per year in a state with 5 or 6 million people. In Texas, where I'm working now, or going to be helping to lead a movement there, I haven't even started counting yet, and I have 117 DPCs. Of course, the population's 30 million.
Those are direct primary care doctors or direct primary care practices?
Clinics. Just speaking of DPC clinics only.
Wow.
But like in Amarillo, there's one with over 200,000 people. So even in Texas, which is probably ahead of the curve,
indeed,
there's still gaps, and one is enough to start. So it depends kind of more even on region than even to classify a whole state. And how do you build it? That's a little loose, right? How do you lead a grassroots movement?
Yes, of course.
All I can really share is our story there. But it's really a lot of what you're doing. It's a lot of what I did in Wisconsin is things like this, getting the word out, doing some education, talking about a strategy that's actually been proven and works, such as adding direct care to your health plan. And what's cool is we can still keep the other hospital systems and the old care. It's just that if the plan pays more, the member is going to pay more. So they're incentivized to go to direct care first through DPC and then through what we call DSC, or direct specialty care. And Wisconsin was completely lacking in that as well. When I first started way back at Merrill Steel, there was no brick and mortar MRI in the whole state, to my knowledge, maybe one or, maybe hidden somewhere.
Totally.
But now, just 3 or 4 years later, we have the whole state covered with brand new GE machines as examples, and surgery centers and infusion centers. So the doctors are just as frustrated. I don't think I have to tell you that.
No, you don't. Yeah.
But they're just as frustrated. So as they see a market and they see an avenue, then they'll start their own practices too, because they don't like working within limits that, that they went to medical school to learn how to treat patients, right? You can certainly speak to that, and they're not allowed to do that in the hospitals as much as they could. So
yeah, it sounds like in order to change the system, you need a lot of components coming up at the same time. So you touched on having more direct primary care clinics so patients get better access to a direct doctor at a known cost, typically lower cost for meds and labs. But then you touched on imaging services and how there's maybe only one freestanding MRI machine in all of Wisconsin. Now you have 10 or 20.
The whole state covered, yeah.
In your book and in some of the presentations you've given, you talked about, you gave a great story about an MRI van or truck that came by. Can you talk about that? And then can you kind of round that out by answering, like, where can employers save the most money by using free market ideas on their overall healthcare spend?
Yeah. Yeah, and the overarching theme is that we're connecting buyers and sellers. So buyers are employers and employees. They're the only buyers of commercial health care, by the way. They're only payers. Sometimes insurance is called a payer. They're a reimburser. That's not their money. But the story at Merrill Steel, where the clinic had contracted with this semi, so this semi, it says MRI scanner on the side of it. And you see it everywhere. It drives all over the state. It goes to hospitals. It goes to all of the hospitals' clinics instead of them having to buy the machine. And it's nice inside, and it pulls up, and the stairs come down. And so we were realizing that we were paying $5,000 to $6,000 for an MRI, and that's higher now, I think, today. Sometimes as much as $10,000 for an MRI, with imaging actually being one of the top costs, one of the top categories for employer plans.
Yeah.
So we said, what if we could bring the truck to our clinic? And then we realized the truck is charging $600 for an MRI. And this was a story I told to employees, because one of the questions that comes next is always, right, is this like a Super 8 surgery? Is this some sort of discount? And in this case, it was a great example because it's the same truck. And if that truck then pulls its stairs up and the tech gets in, the tech is the driver in many cases, and drives to the hospital, in that case 15 minutes away, that MRI became $6,000. And we said, wait a minute, the truck's still charging the 600. Where is the 5,400 going? And it happened in that case to be in a nonprofit hospital. So there was a plug, there is some cost, but we spent $14,000 on a 480 plug, but that plug paid for itself in 2 months. So we start to think buyer and seller economics, taking out all the middlemen, and the buyers are the patients and employers, and the sellers are the physicians or the independent medical practices. And when we connect those two things, really good things happen.
Yeah. Let me tell you some more of my personal problems in terms of selling Plum Health or getting people on board with self-funded or direct primary care models. We usually try to work with employer groups through personal connections, or sometimes even cold calling or meeting people at conferences. Sure. And we hear employers say over and over, I can't believe I'm getting this 20% increase from Blue Cross, or this 38% increase from United Healthcare. And we talk to them, and we have to do a lot of education.
Sure.
Tell me about your process and how do you identify employer groups that are good candidates to work with you, and talk to me about your process. Do you get claims data? Do you run it through a spreadsheet? Do you show them potential savings? Do you prefer talking to their CFO or their HR director or their CEO? Who are the key connections that you make, and how do you paint a picture and show them how they're going to save money?
I think besides employers not being knowledgeable on many of the things we're talking about, because I wasn't when I first started digging into this, so there's a knowledge gap 10 years ago, as when I first started to really learn about it. I'd been around it my whole career. But that is a common frustration, is wait a minute, this is too good to be true, or what reactions are you getting? Why aren't they all over this? I think there's an unhealthy momentum, right? It's this is the status quo path. So we've got to, and the costs are waking them up from that. But I think when employers start realizing that they're getting less for their money, but they're paying more each year, right? That's the wake up call. And then they say, what's the solution? Probably one of the biggest factors is that when a doctor goes and starts an independent primary care, what we call DPC, or starts an independent specialty care, because it's such a monopolized market, they are immediately out of network. A lot of people don't realize this part, is that I always say you could have every possible specialty and primary care around a big employer, and you would be out of their network. They wouldn't be able to use you. So you need both components, and that's what I'm building now in Texas. And what I've done at Merrill Steel is that we change the health plan design. So this helps. This isn't required, but this sure helps. And not only would we make you, for instance, in network, we would make you zero deductible free.
Yes.
Everything that happens at this clinic is free, including any meds that you might help them with, any crutches, stitches, etc.
Yep.
Labs.
So you might build a plan where it's 1A and 1B, where it's 1A is the plan or the insurance or the umbrella policy plus direct primary care. When you go see the direct primary care doctor, it's a $0 copay for any services that you get there. And then 1B is you have that umbrella policy, that insurance policy, but you can go see a typical insurance-based or fee-for-service doctor, but your copay might be $50 or $75 or something like that. And so you're effectively steering the employees to the lower cost primary care doctor.
Yeah, I've seen employers even do it with a fully insured plan. So you just add on DPC. That might potentially add some cost, although you're making the care way better, and then the effect of the DPC might balance that. But with a self-funded plan, there's a saying that we say that this year's claims are next year's premiums, right? What is everyone mostly frustrated with? The premium increases year to year. And the only way to do that then is to build your health plan around a DPC, around primary care. I call it the heartbeat of the medical strategy. And then next level stuff, if you really wanted to do it fully, would be then to change your health plan so that it enables someone like yourself to refer wherever is best. We're not against anyone. We're not against the hospitals. But if there's an independent surgery center here that can do a hip replacement for 20,000, but that hip replacement is 100,000 at the hospital, you give your patient a choice and say, especially if it's within the plan, you can go to this one for free because the plan's happy. You're going to be happier in your next enrollment meeting. And if for some reason the hospital won, well, then refer there, right? We're just after the value purchase.
Yep.
In most cases, that component is missing.
Yep.
And so even when employers add on DPC only, it kind of handcuffs you because then you're referring for all the expensive care straight to the hospital and their premium's still going up. So that's kind of next level. But that is a key component of real long-term success for an employer.
Yeah, we call that care navigation. So we know that if we sent you to the big hospital down the street, the MRI would be $3,000, $3,500. But if you go 2 blocks north, there's regional medical imaging, and they'll get that same MRI for $380, right? So like a 90% savings almost. And then we also know from our patients who have a really high deductible or maybe who are uninsured or paying out of pocket, we could send them to the hospital for a colonoscopy. It might be $3,000, but you could go to the freestanding endoscopy suite and get done for about $1,200. So maybe like a 60 or 65% savings.
Pretty significant, yeah. In some cases, it's even the same doctor. We have a case where the doctor's moonlighting, such as Solstice Health. I don't know if you know Solstice Health in Milwaukee with Tim Murray.
I don't.
You should meet him. But he's a long-term DPC, but then he's added on his own surgery center. And you could have Dr. Smith perform the hip replacement in his office that's $20,000, and then the hip replacements that's $1 to $150. Dr. Smith is making more on the $20,000 surgery than he is on the very expensive one. It's the same doctor.
Yeah, that's truly wild.
Yeah,
really pulling back the curtain on some of those hospital-based charges or facility fees and all those things that go into the cost. So. You've made a big career change. Now you're the VP of Healthcare Innovation. Tell us about your work with Sedera and getting solutions for all size employers and employees.
Yeah, I've joined on with them, and they had the Health Share Group plan, which we're going to enhance over time, but that primarily addresses the 50 and under employers, which those employers, by the way, for DPCs and yourself, those employers are much hungrier and much more flexible, as maybe you've experienced.
Yes, absolutely.
They're ready to change tomorrow. They're like, give me a solution. The bigger the employer, the slower the change. But that was really the gap for health admins, is that they wanted a self-funded plan as well, so that we could have solutions for all sizes of employers. So we're constructing this plan that's funded, that's going to be funded by a captive. And then it'll also have a spend strategy, or maybe better said, a medical strategy that has both DPC plus DSC. So you get great care, but then we also manage the plan spend, and we can manage then the premiums, therefore.
And are you only working in Texas, or are you working in other areas as well?
It's going to launch in Texas, which is probably a great place to do it. But then the plan is to take it where the market leads. So it certainly could be available in many other areas as well before too long.
And as a plug, thank you so much for being here, spending the time flying in from Wisconsin just for this interview and the conference tomorrow. Of course, we're having a Michigan conference around direct primary care and healthcare innovation for employers. So thank you for making the trip out. If somebody wants to work with you at Sedera, how can they reach you, or how can they find you?
Yeah. So I have a couple of active email addresses. I'm on LinkedIn, first of all, so connect with me on LinkedIn. And then also my address at Health Admins is MOHRT at healthadmins.com, or also dftbconsulting@gmail.com. So Don't Feed the Beast.
Beautiful. Yeah. And let's talk about that. Your book, Don't Feed the Beast, amazing, about getting companies off of typical health insurance, aka the beast, and into a self-funded or health share type plan. So can you talk about the book, its success, all that?
Yeah, it's really the second book of its kind. And there's been more than 2 success stories from employers. I mean, they are lacking. But that's when I had met John Trinas, who was the original one, who's also from Wisconsin. Now John's about 87-ish, so John's up there.
Yep.
But he's the original pioneer. But when I first started looking for books or solutions, that was the only one I found specifically. So that planted the seed for me. I'm like, I think we're going to need, maybe if this, if all this works, we're going to need another one. So that was something I was thinking about for a long time. But this is really a guide. It's a great educational tool. We have DPCs that hand it out. We have advisors that hand it out. We have TPAs that hand it out. Just as in, I used to joke when I first succeeded at Merrill Steel and my phone started ringing, we won awards and different things. And my joke was, they said, can you explain how you did this? And my joke was, what are you doing the next 4 hours? Because it's like, right? There's no, there's no like 5-minute thing here. Yeah. There's like, oh, you got to do this and this and this and this. And so the book is a great way to solve that. Mm-hmm. Not everybody's a reader, but I tried to, and the audiobook's coming out soon as Amazon will hit approve. I don't know what they're waiting on. They're kind of giving me a hard time, but as soon as that's ready, it's submitted. So that'll be out there. I have the Kindle version out there.
Great.
But I had a CFO once say, I'm not a reader, right? And I'm a farm boy, so I tried to make it fun and not textbook. But he said, I am absolutely not a reader, but I took your book with me that you gave me on a plane trip, and I read it cover to cover. And let me tell you, I trust you, and you are very passionate about this. And so even if you're not a reader, I guess I would throw it out there. And then I would just add, mark it up. Like, this isn't some pretty thing to put on the shelf. Get your highlighter out, mark it up, mark the pages and absorb it. And there's other great ones out there too. But really, I think that's where the book can be of most help.
Well, thank you for writing it. It is a great guide. And I am really excited about the momentum that's building around this, free market healthcare movement, direct primary care movement, more advisor role instead of just health insurance brokers. Mm-hmm. And there's a big difference, right?
Very.
And there's like a fiduciary responsibility there. I'm excited about all these pieces finally coming together in Michigan, mm-hmm. so that we can help more people with excellent healthcare at an affordable cost that's not going to cost $24,000 a year per employee and their family. So thank you for leading the change in that regard. And I'm looking forward to a great conference tomorrow.
Yeah, I think it's great what you guys are doing in Michigan collectively, and it really is a lot of sweat equity. I mean, some would have an event and expect to get 300 people on the first one. That's usually not the way it works. I mean, you guys are a little ahead of that. Yep. But just keep going, and more will join the movement. And yeah, I think where there's a need, then there's a desire for a solution, and you guys are it. So kudos to you and all the work you've done.
Awesome. Well, thank you again, Matt. And this concludes episode 4. Thanks for watching. And we're looking forward to continuing this change here in Michigan and beyond in terms of lowering healthcare costs and making healthcare access better in the state of Michigan and beyond. So thanks again.